Today we'll be talking about pregnancy and valve disease. So I have no disclosures, and I'm just going to make my box smaller so I can see what's going on. All right, so I have no disclosures. Today we're going to talk about the hemodynamics in pregnancy, risk stratification for cardiac pathologies as well as in pregnancy, left-sided obstructive lesions, right-sided obstructive lesions, regurgitant lesions, a little bit on prosthetic heart valves, and then a touch on anticoagulation as well. So in terms of understanding what happens to when something goes wrong with the heart and sequelae in pregnancy, first we have to understand what the actual hemodynamics of pregnancy are. And I will say this, having had 2 children, is that there is a big change that happens, and all of what you learn in medical school in terms of the hemodynamics and changes with pregnancy in the body are 100% true, and it goes along with exactly what's listed here. So there's a rise in cardiac output by 30 to 50%, which is very high. And this is due to increased stroke volume by plasma volume expansion that happens early on. A lot of that volume comes in the first trimester and the second trimester as well. And this is later on due to an increased heart rate at the later stages in pregnancy. So some more of the tachycardia that we see with later stages in the 3rd trimester. Plasma volume expansion with lagging red blood cell mass increase leads to this physiologic anemia. So there's a mismatch in terms of how much plasma you have and how much red cell production there is, and the red cell mass. And so then this further impacts your cardiac output, making your body think that it's anemic and it needs more flow, and so then it augments the cardiac output further. Increased flow, as I mentioned, can cause a physiologic flow murmur if you hear on exam, auscultate on exam. And there's also an increase in transvalvular gradients with pre-existing valvular lesions. And so we'll get into how obstructive lesions are very different and often less tolerated than regurgitant lesions for this reason. And then lastly, something that'll be much more familiar is the hypercoagulable state that happens in pregnancy and increased risk of thrombosis. So oftentimes the questions and concerns in these patients are pulmonary embolisms towards the end of pregnancy when they have tachycardia and dyspnea. So the physiologic anemia, just to touch on that a little bit further, you have the plasma, the whole blood, and the erythrocytes. And so when your blood volume disproportionately increases in terms of the plasma, but the erythrocytes haven't caught up yet, you'll end up getting what looks like a physiologic anemia. And so this is dating back from older studies in the 1980s. Then when you look at what happens to heart rate is in blue, stroke volume is in red, and cardiac output is the top line in the gray. Over your weeks of pregnancy and the percent change that happens, initially you start off with normal numbers, cardiac output, stroke volume, and heart rate. And then as you go on further in your weeks, your heart rate starts to slowly increase. It's not as dramatic in terms of the percentage change. But if you look at the gray line, your cardiac output, as I mentioned, changes somewhere between that 30 to 50% range. And so then your stroke volume will be also have a rise as well, but the stroke volume sort of dips down as your heart rate increases. And so then that's what is a maintenance there of your cardiac output. So by 38 weeks, your heart rate has increased by roughly 10% from its baseline. Your stroke volume has increased by roughly from 30%, and then your cardiac output somewhere in that 30 to 50 range. So this is a much more detailed slide, and basically it's a summary of all of the changes that happened in pregnancy and at what weeks during the pregnancy. And so it's just really another way of showing the same concepts of cardiac output, stroke volume, and heart rate. On the right side of the slide, you can see the different colors that are sort of describing it. And the real takeaway is, if you look at the top line, the blue sort of turquoise color is the plasma volume. So as there's a big plasma volume expansion, that is what happens and what drives a lot of these physiologic changes in pregnancy. And then again, you can see with the gray line here, the cardiac output sort of levels off as you get further into pregnancy, and then post-delivery, it drops dramatically. That's another big difference on these slides. Overall, in this slide, it's basically a general idea that things that you don't need to use as much will slow down, and things that you need to use a little bit more to help the fetus grow will increase. So gut motility slows down. Hepatic clearance, though, will increase so that you get all the toxins removed. Your kidney function increases dramatically to also remove and clean out your system, so you end up urinating more often. You're hyperventilating, but your lung capacity decreases because of the the fetus taking up space. And we mentioned already the hypercoagulable state that happens from these changes in clotting factors and fibrinogen. So going back to medical school and the classics, the cardiovascular exam, I wanted to go through what are some of the percentages of what you'll hear in pregnancy and what is considered more concerning and less concerning. So you have your A2P2, which is the closure of the aortic and pulmonic valves, and then you have mitral valve closure and tricuspid closure. And so this differentiates your systolic time period versus your diastolic time period. So when you have a systolic flow murmur, that's about 96% of patients that are pregnant, and we discussed how this is related to the increased plasma volume, increased flow across the valves, and then what can cause this flow murmur. What is more rare is on the left of the screen, you'll see the fourth heart sound right before your mitral valve closure. And what is also rare is a diastolic flow murmur. So in general, when we talk about the cardiac exam, systolic murmurs that are late peaking are usually more concerning, and any diastolic murmur is something that needs further investigation. So at the very basic level, a transthoracic echo. When in pregnancy, this goes sort of even further to say that very often, majority of patients will have a systolic flow murmur, but the diastolic murmur, again, will not be heard as often, but if heard, needs further investigation. The loud heart sound will happen from the increase in volume, and so for the third heart sound, so that'll be about 84% of patients as well. And then also because of this volume expansion, you'll get this split in the first heart sound, so 88% there. So those are more common, but when you hear any sound right before the mitral valve closure or a diastolic murmur, those require further investigation. So to summarize here, an S4, a loud systolic murmur, a diastolic murmur, a fixed split S2, which is, sort of going back to concern about atrial defects, atrial septal defects, or an ejection click, which is what you might hear related to the mitral valve, is something that requires further investigation and a transthoracic echo for pregnant patients. So let's take it by trimester. So the first few slides that I have are basically just multiple different ways of breaking down exactly what happens hemodynamically to the body and to the heart in pregnancy, so that when we get to the obstructive and regurgitant lesions, the pathophysiology will make a lot more sense. So in the first stage, essentially first trimester, which is considered conception to 12 weeks, you have a rise in cardiac output, rise in plasma volume, as we mentioned, and a slight change in systemic vascular resistance. In the second trimester, weeks 13 through 26, you have less of a rise in cardiac output, which we saw on the graphs, reduced vascular tone, so you have more venodilation, decrease in systemic vascular resistance that goes along with it as well, and then fetal thyroid development has not yet occurred. So there's less risk from maternal radiation in terms of the fetal thyroid at this point. In the third trimester, so that's technically weeks 27 through 40, you have a plateau in your cardiac output, as we saw in the graphs, and a slow increase in systemic vascular resistance until term. Obviously, this sort of mirrors exercise physiology, where you have an increase in systemic vascular resistance, but it can't exceed what the body needs to do. And so your SVR isn't going to go up dramatically, but it will drop off significantly once you've finished your exercise, or in this case, once you deliver to term. And so now let's go by stages of labor. So a lot of this is less familiar to those of us, in general medicine, rather than back from medical school in our OBGYN rotations. It becomes even less familiar once you subspecialize in cardiology. It then becomes familiar again if you were to have a baby. But the stages are broken down in terms of 0 to 10 centimeters, delivery, placental delivery, and then the first hour post-delivery, excuse me. So in the first stage, you have a further increase in cardiac output by 30%, increase in systolic and diastolic blood pressures, which are due to the contractions. And then this concept of autotransfusion, which basically is circulation of the placental fluid to the systemic circulation with each uterine contraction. So trying to really augment the flow that's happening in the systemic circulation as the further demands are required during delivery. During stage 2, there's facilitated stage to minimize Valsalva time if there is any concerns in terms of cardiac pathologies, and we'll get back to this point once we go over the lesions. And then in the first hour post-delivery, there's an increase in cardiac output up to 80%, which is normalized in a normal individual normal cardiac output from the start, but in someone with an abnormal valvular disease or cardiomyopathies, that was something that will be of greater concern. But there is a normalization of the heart rate. So essentially what happens is the tachycardia resolves, your stroke volume then will increase significantly to get all of that autotransfusion and flow that's has been augmented in the system, and then your cardiac output will be increased as such. And then postpartum, we go into immediately, as we just discussed, 24 hours postpartum and then 6 weeks postpartum. So 24 hours post, you have a continued elevated cardiac output, increase in preload due to the relief of the IVC compression by the uterus. And this is the caveat to this, of course, is if there's no significant blood loss and that there's no other compensatory mechanisms that are happening. And this peak in hemodynamic shifts occurs at 24 to 72 hours. So post-delivery, in the first 2 days, essentially, you'll see a tremendous amount of venodilation, increased leg edema, increased volume, because all of that is shifting back out from the increased plasma volume and volume retention that's happened during pregnancy. 6 weeks postpartum, you'll get a gradual decline in that plasma volume, gradual natriuresis. And the bigger concern, though, is an increased risk of thrombosis, and that peaks at 6 weeks and continues till about 12 weeks postpartum. So I'm not going to touch on peri-partum cardiomyopathy since that's a much larger entity, but this, just as a side note, this increased risk of thrombosis in these 6 weeks postpartum is the rationale for anticoagulation in patients with an EF less than 35% in peri-partum cardiomyopathy patients. Okay, so tachycardia and congestive heart failure. So basically on the left side, you see the number of events, and on the bottom portion, you see the weeks pre and post delivery. And so the big sort of concerns that come through arrhythmia-wise is in the second and third trimesters, not as much in the first trimester. Pulmonary edema will settle in more towards the end because of the increased volume expansion. And so you see the difference there. And labor and delivery basically is the thing that will offset everything. So for that time period, you have a volume expansion and sort of a quieting of the heart rate that will not give as much basically because the whole focus then is shifted into the delivery portion as well. And so if you were floridly tachycardic or if there's a significant increase in that tachycardia during delivery, you'd have less cardiac output or compromise in that sense, and not necessarily be able to maintain your blood pressures to deliver. But afterwards, you see a lot of these compensatory mechanisms kick back into place. So cardiovascular disease in pregnancy. Now that we understand a little bit more about the hemodynamics of pregnancy itself, let's go now into how it relates to when cardiovascular diseases occur. So it's present in about 1 to 4 pregnancies, 1 to 4% of pregnancies. And the risk factors include advancing maternal age, diabetes, hypertension, preeclampsia, and multifetal delivery. Preconception counseling is essential. And the basics are important: complete history, physical, 12-lead ECG, and a baseline echocardiography for anyone who has a concern by their physical exam, as we mentioned on the cardiac exam slide. Normal echocardiographic findings in pregnancy include mild chamber dilation, a very mild increase in ventricular thickness, and a mild increase in the gradients, and this is due to the plasma volume expansion, as we mentioned. Exercise stress testing for known valvular heart disease is something that's actually from the European Society guidelines. And in this instance, 80% of reaching your max predicted heart rate is a strong predictor of with insufficient evidence towards causation of spontaneous miscarriage. So that's a lot of words to basically say, if you have significant cardiovascular disease and you cannot get to 80% of your max predicted heart rate, then there's a risk that you carry of spontaneous miscarriage. However, routinely, we're not stressing patients before pregnancy, and routinely, we are not stressing patients once they're in their, once they are pregnant, unless there is something specifically concerning from a cardiovascular standpoint or from a symptomatic standpoint. So in terms of risk stratification with cardiac disease in pregnancy, there are three main sort of researched and well-known risk stratification systems. So there's the CARPREG, the ZAHARA, and the WHO classifications. And just to go into the background of them a little bit more, for CARPREG, it was the study was 562 women with congenital and acquired heart disease. 13% complicated by pulmonary edema, arrhythmia, stroke, or cardiovascular death.
Does it make a big difference? Does that piece of it? Because I feel like in recent years it's kind of like pulled out, but I don't know as far as like the competitive fellowships, maybe it is still.
So then the second risk stratification here is women with congenital heart disease, and the third risk stratification is from the WHO, and this is more focused on women with congenital and acquired heart disease, further defined into 4 classes ranging from low to high risk, and of course high risk category being the increased risk of mortality with pregnancy. And so this is where significant counseling is important, because pregnancy can be life-threatening, and so then
how many have you done?
Pre-pregnancy counseling
like, is so active in research.
All right, so here we have again more detailed information on the predictors of maternal and cardiovascular events, and the predictor of actually neonatal events. So if you see, what comes into both slides is NYHA classification, obstructive heart lesions, and one thing that will come into play, one thing that will come into play is the mechanical valve prosthesis and how anticoagulation factors in for both. And so we will also touch on that in a little bit. All right, so to get into how these risk stratification systems actually work, for CARPREG, you basically get 1 out of 4 points
like
for each of these sections. So NYHA classification elevated to 3 or 4. An EF less than 40%, obstructive lesions, as I mentioned, which are more challenging in pregnancy than regurgitant lesions, and a prior cardiac event.
Is that this one that like everybody
if you have
joined on?
More than one
okay, that's a different one.
Could we make sure that everyone is muted, please? Thank you.
I love that.
So if you have more than one for your event rate ends up being 75%.
Just like start asking around like fellows or
like
other residents who are doing GI.
So the way I did it, so I find cases to write out.
I apologize, Vaani. I'm not the host.
It's okay.
I can't mute them.
It's okay. Sherry Golami.
Can everybody please mute your mic, please?
If Sherry Golami could please mute, thank you. All right, so going back to the risk stratification for the ZAHARA. So as you can see for the ZAHARA, there is significantly more points and factors that go into your scoring system. The event rate basically still puts you at 70% if you have a significant number of pathologies. But the main thing to look at is obstructive lesions are what give you the most points, so 2.5. Mechanical valve gives you a 4.25 point here as well. And the pulmonary hypertension is also something that will factor in. So these are really the things that are more concerning, and so why we're going to spend some time discussing left-sided obstructive lesions. So left-sided obstructive lesions, by definition, here would be a mitral valve area less than 2. an aortic valve area less than 1.5, or an LVOT gradient greater than 30. Now, technically, these don't put you in the severe category. So, for example, aortic valve area less than 1.5 gives you, you can have a spectrum of mild, moderate to severe aortic stenosis. But the concern is that if your valve is not normal and there's some element of obstruction, then during pregnancy, it can be further exacerbated. All right, so again, here, I'm just going to highlight the specifics here in terms of the WHO classification and what puts you in the class 4 pregnancy is contraindicated. So there are several categories here, but the severe mitral stenosis with severe symptomatic aortic stenosis basically means that the valve needs to be taken care of first, and then pregnancy can be pursued. If there is if there's an issue in terms of getting pregnant and having one of these lesions, that is something that then has to be dealt with while pregnancy is ongoing. So those patients have either gone for mitral balloon procedures or aortic balloon procedures. And again, that we won't touch on in this talk, but is a much larger discussion and conversation. But the goal would be to handle those obstructive lesions prior to getting pregnant and having pre-pregnancy counseling as such. Less concerning are, in terms of no detectable risk, are mild pulmonary stenosis, mitral valve prolapse, regurgitant lesions, and those are usually generally more well tolerated. So here, just to give you the breakdown of percentages of numbers, the maternal cardiac event rate risk. So when you get into the class 4, the reason it's considered pregnancy contraindicated is because the maternal risk and cardiac event rate exceeds 40%. I mean, and that's significantly elevated. I mean, I think even in the patient-dependent classification section, where you have 11 to 17%, would be a significant conversation to have with the patient about their risks during pregnancy and how they want to move forward. So there's a registry on pregnancy and cardiac disease called ROPAC. And so the breakdown here tells you that there's a fair amount of data that is missing as well, but really the mitral stenosis and mitral regurgitation make up a significant portion of the pathologies for cardiac disease in pregnant patients that were looked at from 2007 to 2011 by the European Society of Cardiology. It was in 60 hospitals in 28 countries, so it's a really nice registry that spans all types of pathologies from all backgrounds. 1,321 women were included. Congenital heart disease was present in 66% of those patients, and valvular heart disease in 25%. So what's interesting is that by additional 5 years later, they almost essentially more than doubled the number of pregnancies that they were monitoring. And they had an increase or saw more numbers of women with moderate to severe aortic stenosis and an increase in number of patients with rheumatic mitral disease or rheumatic stenosis. And so what really gave us more information about this was when to advise against pregnancy. Now this is a really, difficult topic. As a mother, I can understand this tremendously. I'll tell you personally, as someone who's had a miscarriage, I can understand this tremendously. When you want to have a child and there's a concern, it's very, very difficult. And I think this is why it's really wonderful in cardiology. There's sort of this emerging cardio-obstetrics field, because a lot of this pre-pregnancy counseling is, I think, done wonderfully by cardiologists, but also facilitated by subspecialists who have a true, their fingertips understand this really well. So advice against pregnancy, when you really need to have an in-depth discussion, is when things are truly severe. So severe arterial pulmonary hypertension, severe symptomatic obstructive lesions, AS, MS, pulmonic stenosis, but not as significant. Hypertrophic cardiomyopathy would factor into this when you have a significant LVOT outflow tract gradient. Coarctation that has not been adjusted or assessed in childhood. Left ventricular dysfunction. Now, this says an EF less than 40. I would say that the bigger issue is class 3 or class 4 in terms of functional status. And then the biggest issue is a prior peripartum cardiomyopathy with a recovered EF and the risk of recurrent cardiomyopathy with a subsequent pregnancy. Dilated aorta, 4.5 centimeters or greater, and then severe cyanotic disease, which is concerning for maternal congenital heart disease that hasn't been treated. So in terms of counseling, management, and delivery, there's some really wonderful review articles that came up in 2016 from Dr. El-Qaim, who's one of the leaders in research and reviews on peripartum cardiomyopathy. And so he put together this slide that one of the big things that I think is a sort of a myth in terms of heart disease is that you have to have a C-section because it's more controlled. And what's interesting is if you look at the different categories here, so valve disease, congenital heart disease, complex congenital heart disease, pulmonary hypertension, aortopathies, and dilated cardiomyopathy, the only one that actually recommends a C-section is for aortopathies. And so why is that? What do we give in terms of counseling for patients with dilated aortas or aortic aneurysms? To avoid Valsalva, to avoid significant weight, avoid significant bench pressing, weightlifting with Valsalva, because you're increasing your shear stress and the stress forces on the aorta. So in aortopathies, if you're going to push with a vaginal delivery, you're increasing your intra-abdominal pressure, and this can actually cause more damage than good in terms of aortic diseases. But every other category, vaginal delivery is actually preferred because you can have more control over the amount of fluids and volume that is going into the system. And so this one I thought was, really important to touch on. And, there's additional information in this slide in terms of some of which we touched upon in terms of management, but the real focus here is the delivery, that it should always be a C-section if you have some problem with the heart. It is actually not true, and it's actually more beneficial in most cases to do a vaginal delivery in a controlled setting. Okay, so now to dive into the actual lesions and details a little bit more. Left-sided obstructive lesions, so aortic stenosis is most often due to a bicuspid valve, usually in these younger patients. Associated aortopathies are common, coarctation about 5%, less common. A risk of is highest at times of increased cardiac output, so this is towards your 3rd trimester. Maternal mortality is low though, 1%, thank goodness. And severe stenosis is associated with adverse fetal outcomes, which usually are preterm birth and low birth weight. So in one study, they saw that out of the 20, actually this was from the ROPAC registry. So of the 2966 pregnancies and the 96 women with significant aortic stenosis, it was statistically significant in terms of low birth weight compared to those that did not have severe aortic stenosis. Mitral stenosis is significantly tolerated less favorably with high morbidity. What happens here is you have LA pressure increase because of the mitral stenosis, which causes a back pressure and pulmonary edema. The pulmonary edema then is further exacerbated with tachycardia, decreased diastolic filling time, increased pulmonary vascular congestion, and then associated pulmonary hypertension. There's a high risk of and a high incidence of occurrence of atrial fibrillation. This then adds into the difficult decisions about anticoagulation, which we'll get to in a few slides. And the pathologies for the fetus are increased severity of fetal growth restrictions, low birth weight, and then again, premature birth. And actually, just to go back to this slide for a second, a lot of what happens with the preterm birth is because in terms of the health of the mother, the calculation changes, and some may have a planned delivery earlier on, which then ends up into a preterm birth as well. So for aortic stenosis, how do we handle that? Serial echocardiography once per trimester is one of the current recommendations. In the 3rd trimester, transthoracic echocardiography should be performed around 32 weeks, which is at your peak of the hemodynamic load. And we interpret this in the context of these hemodynamic shifts. So the gradient increases with increased flow, as we know. But reliably with our calculations by flow in echocardiography, we can calculate the aortic valve area to assess whether or not there's actually been a change or a concern that needs to be interrogated and invested further. Imaging of the ascending aorta, so the size and presence of coarctation for bicuspid valves, are done early on, and so that doesn't necessarily factor into further months into pregnancy. But fetal echocardiography is often offered to women with a bicuspid aortic valve, and this is due to the genetic transmission risk. So transmission of congenital heart disease, left-sided obstructive lesions, outflow tract malformations is about 10%. And so part of this would be sort of a dual pre-planning. So pre-planning for the mother in terms of how to manage the aortic valve, if there's any stenotic or regurgitant lesions in the bicuspid, and then knowing for the fetus if they need to preemptively plan for any obstructive lesions post-delivery. So here's a case of a bicuspid aortic valve in a 31-year-old female who as a teenager had undergone balloon valvuloplasty for severe aortic stenosis and came in for her first antenatal visit, had a dilated aortic root with a mean gradient of 42 and a calculated valve area of 0.8. So basically when she had, during pregnancy, her gradients increased to a mean of 59. So this is mainly due to the increased volume across the aortic valve with causing an increased gradient, but obviously her valve area has stayed the same. And at 32 weeks, they decided to do urgent delivery mostly because of preeclampsia. And as we mentioned, many of these obstructive lesions tend to have associations with the fetus as well. And in this case, there was a small ventricular septal defect. So medical management for these patients, now medical management is sort of misnomer in terms of aortic stenosis, but in terms of how to get patients through a procedure, then that's where we look into how their hemodynamics are and how their volume status is and their what medications can be used to help those hemodynamics. So oftentimes severe aortic stenosis, progressive gradients with increasing symptoms, you admit for bed rest. You managed them with diuretics plus caution on not over-diuresing the patients because this can lead to hypovolemia, hypotension, and then the bigger catastrophic sequelae of it is decreased placental perfusion. If they are tachycardic and in afib or flutter, you can cardiovert safely and with restoration of normal sinus rhythm. Beta blockers, calcium channel blockers are used for management of tachycardia, and then associated aortopathies have to be interrogated as well. So invasive management, as I alluded to in a prior slide, is aortic valvuloplasty. So it's the balloon aortic valvuloplasty for refractory cases. This would be pursued after the first trimester when organogenesis is completed in the fetus. You use abdominal shielding for your fluoroscopy procedure with very experienced operators, and it's not performed prophylactically because the whole point of a valvuloplasty is that it's a temporizing procedure. This gets them through delivery, and then afterwards they would go for surgical interventions or further discussions. If for some reason a surgical aortic valve replacement is necessary, then the ideal is to have it in the second trimester. So after organogenesis of the first trimester and prior to fetal viability at 23 weeks to maximize fetal outcomes. There's a very low maternal mortality, but fetal mortality with maternal valve surgery is high. And that's the reason you would want to intervene before fetal viability, which again is a controversial topic and further, again, merits further different discussion. But statistically, the numbers are that the mother will do quite well with these surgeries, but the risk in terms of going on cardiac bypass and the volume and the perfusion to the placental tissue can be compromised, which is part of what factors into the high fetal mortality at 20 to 30%. And so far, there's, to my knowledge, there's no reported cases of TAVR in pregnancies during pregnancy. So if you look at preconception with non-severe numbers, no symptoms, normal EF, you're good to go. Preconception with abnormal numbers, so elevated gradient over 4, increased peak gradient and mean gradient, which would translate to above 40. Then you look at their LVEF, their exercise tolerance, and you actually can check a BNP. If those factors are normal, then you're okay to proceed with relative safety. And if they're not normal, it merits further discussion. And then during pregnancy, if you end up having further discussion, women chooses as they want and then get pregnant, the plan then is to go by EF, and by symptoms. So if there are symptoms, then you have to do medical therapy and plan on either a surgical intervention or a balloon valvuloplasty, depending on the scenario. If there are no symptoms, then you monitor by EF, and again, that takes you down both routes. If their EF is normal and they've maintained that through the pregnancy, most likely that shows that their LV is it has enough reserve to be able to handle the hemodynamic shifts that will happen during pregnancy and post-delivery. All right, so bicuspid and aortopathies, low incidence of aortic dissection, about 3 per 100,000 patient years in pregnancy. There's a higher than general population risk, of course, and the largest study, though, was only 88 women with a BAV and aortopathies. So that's a bicuspid aortic valve, not a balloon aortic valvuloplasty here. 216 pregnancies with 186 deliveries, 10 went for surgery, and several had progressive dilation. And this is essentially what we learned from the Marfan's population, and extrapolating Marfan's patients in pregnancy and their risk for aortic disease and progression to bicuspid patients who have aortopathies concurrently. And so the numbers really come to the more generous diameter. So pregnancy should not be advised in women with with a bicuspid aortic valve and an aortic diameter of 5 centimeters. So consider cardiac MRI without the gadolinium if the aortic size is 4.5 centimeters to get a further clarification on the sizing. And one thing that you would want to do is monitor by transthoracic echocardiography every 4 to 6 weeks if the aortic size is greater than 4 centimeters to assess for progressive dilation. So 5 millimeters would be very progressive dilation that you would want to monitor as you're going through the pregnancy. So here are the breakdowns of the different vascular pathologies and the connective tissue disorders that go along with where we get this information of dissection risk. That's essentially what the issue is. And so if you see there's specific areas for the location of the aneurysm, but if you go to this middle section of the slide, the risk of dissection is about 1 to 10%, which is considered high. With bicuspid aortic valves, the risk is lower. And so that's why now, if you look at the very bottom of the slide down here, that is why for the bicuspid aortic valve at the bottom portion, the cutoff number is higher. So 5 centimeters or 50 millimeters is when the advice comes for being cautious against pregnancy. And the other numbers, though, are all in the lower threshold, 4.5 centimeters. So management strategies for pregnant women with aortopathies, as I mentioned, the bigger thing is that there is a push towards C-section when you have significant aortopathy and aortic dilation. If you don't, and you have reasonable follow-up, as we mentioned, every 4 to 6 weeks with transthoracic echoes without rapid progression or growth, then a vaginal delivery is still a reasonable option. But if you see any of those parameters change, so increase in size overall or an increase in diameter by more than 5 millimeters per study change, then you would push towards cesarean section or prophylactic early delivery. And here's an example of an aortopathy with a dramatic aortic root dilation of a Marfan's patient. So this is a transthoracic echocardiogram of a 29-year-old with severe dilation of the aortic root and severe aortic regurgitation. The patient presented for the first time late in her first trimester and actually had surgery. So she had a successful valve-sparing root replacement at 12 weeks gestation. So optimizing the not having it in the first trimester when your risk of spontaneous miscarriage is the highest. definitely pursuing surgery during second trimester when you're going to have the volume expansion and the shifts, but before you have fetal viability. And then this patient was able to successfully deliver. So I mentioned this on one of the previous slides, but just to give you some numbers, the NT pro-BNP number greater than 128 at 20 weeks pregnancy is predictive of events later in pregnancy. And so if your number is less than this, you have some relative comfort is, you know, I think a liberal word, but some relative indication that the pregnancy will be well tolerated. If the number is higher than this, then the patients usually go for more often screenings, either with their high-risk OB/GYN, with their cardiologist, or a combination of both. Okay, so moving to mitral valve disease, adverse maternal events happen with NYHA classification 1 and mitral stenosis. Isolated severe mitral regurgitation with heart failure in 23% of patients. There was another study that looked at incremental rates of pulmonary edema with mitral stenosis. And so this is what we were describing before. The more severe mitral stenosis you have, the more elevated left atrial pressure, and the more risk of pulmonary edema with progressive volume expansion as that occurs in the normal hemodynamics of pregnancy. And premature delivery with maternal mitral stenosis was about 33% with patients with severe disease. If you look at the variable outcomes in patients with and the variable predictors, the major factors here that align are severe disease. So the severe mitral stenosis, severe mitral regurgitation, and pulmonary pressures greater than 30 will give you a greater risk of adverse events. Here's an example of rheumatic mitral stenosis. So here you have a doming of the anterior and posterior leaflets of the mitral valve indicated by the arrow stenotic mitral valve. A 43-year-old woman with moderate rheumatic valve stenosis, mild mitral regurgitation, and a severely dilated LA. Mild pulmonary hypertension in the 3rd trimester, had congestive heart failure. And so she was medically managed through her pulmonary edema with diuretics, beta blockers, allowing for the gradient to be managed by decreasing the heart rate and then moving towards successful delivery. So in these patients, what becomes critical is anticoagulation, independent of a CHA2DS2-VASc, but these are younger women anyway. And independent of your CHA2DS2-VASc gives you the risk of atrial fibrillation, as well as if there's atrial fibrillation, risk of thrombi. Medical therapy for heart failure, including diuretics and beta blockers, as I mentioned, for controlling the tachycardia. Avoiding tocolytics, so this is specific to the OB/GYN and them knowing the mitral pathology and how they will manage, because tocolytics, which include mag sulfate, nifedipine, indomethacin, these are beta mimetic in terms of worsening the tachycardia, and they cause an increase in the left atrial pressure when you have mitral stenosis. Oxytocin is an alternative. This actually will help the hemodynamics. And then, as I mentioned before, one option in refractory cases where there is very limited control of their pulmonary edema from diuretics and beta blockers and management and worsening heart failure is a balloon mitral valvuloplasty that can be performed either preemptively from surgery, from pregnancy, or during pregnancy if needed. Okay, so moving on to right-sided obstructive lesions, severe pulmonic stenosis is usually very well tolerated. And this is because the volume side that's coming from the right to the left isn't impacted as much in terms of your backflow and pulmonary edema. You do monitor for right-sided heart failure, although this is more rare. And there is an association of isolated pulmonic stenosis with an increased risk of hypertensive disorder in pregnancy. However, the evidence is quite poor. And the management for that is very straightforward in terms of monitoring the blood pressure and monitoring for preeclampsia. There's a stronger association with thrombotic complications. And then this is very similar to the non-pregnancy indications for balloon valvuloplasty of pulmonic stenosis, where if you're symptomatic with a gradient by right heart catheterization of 30 millimeters of mercury, then that would be an indication for intervening. And if you're asymptomatic with a gradient of 50. All right, moving to regurgitant lesions. So annular dilation occurs due to the physiologic volume overload states. As we mentioned, you have mild chamber dilation, the increase in flow. So regurgitant lesions will have an increase in severity because more volume is going across the valves. And it's generally well tolerated because the heart's compliance is also increased during pregnancy. And so that allows for more movement and management of the increased volume. Symptoms manifest at the peaks of cardiac output. So second trimester, third trimester, and the first 24 to 72 hours postpartum. This is when you'll feel more dyspneic, or you may feel more tachycardic from the increased volume and the shifts. And the management is really with diuretics and afterload reduction. So helping the forward flow by having an afterload reduction and helping volume overall with diuretics. So what's tolerated in pregnancy is hydralazine and nitrates, the diuretics, as we mentioned. And then in terms of needing something postpartum, enalapril is reasonable. For mitral regurgitation, with normal ventricular function, asymptomatic, mild, moderate, severe is better tolerated than stenosis. And we've already gone over the obstructive lesions. There's an associated decrease in peripheral vascular resistance and decrease in blood pressure during pregnancy, which actually helps mitral regurgitation be less concerning, less severe. But if you have severe regurgitation and LV dysfunction, then you can be further symptomatic from these increases in plasma volume. And again, we've mentioned the mainstays for management is diuretics and beta blockers, calcium channel blockers if there's no cardiomyopathy. For pulmonary regurgitation, the most common comes after tetralogy of Fallot repair. So patients with congenital heart disease that are then into adulthood and planning for pregnancies. Post-valvuloplasty, pulmonary stenosis, and then the risk scores, as we mentioned from the ZAHARA, give you more variable rates for right-sided heart lesions and arrhythmias, and the highest risk if there's severe regurgitant or right ventricular dysfunction or hypertrophy. So, and the transmission risk to the offspring is about 3 to 5%, so less than some of the other ones that we've covered, but still a fair number. Moving on to prosthetic heart valves. So in childbearing age, the big controversy is whether or not to even put in a mechanical valve, so a bioprosthetic or a mechanical, for a young woman who has a valvular cardiomyopathy or valvular heart disease and needs intervention. So the suggestion of pregnancy-related increased structural valve deterioration is that there's very poor evidence of needing redo aortic valve surgeries with no mention of prior pregnancy history. So that's basically to say, if you needed surgery for your valve and then you were to get pregnant, there really is no great data to say that pregnancy worsened your valve disease and that you will need a repeat surgery later on. One option is Ross procedures at experience centers, where the aggregate data is from, most recently is from 2010, with early mortality of 2 to 3%. I gave this talk last year when I was at Sinai, and so there's a plug for them right there. But their rates are wonderful, with a very experienced surgeon who has nearly zero mortality and is very well known for their Ross procedures, Dr. Stelzer. Several small studies evaluating prosthetic valves and maternal and fetal morbidity. And then from ROPAC, one of the specifics looking at the prostheses was they looked at, in their registry included 134 bioprosthetic patients, 212 mechanicals, and the rest without valve prostheses. And valve thrombosis was the most common complication. Hemorrhagic complications occurred as well, and then the majority of them had no adverse events. So there was a higher incidence, though, again, of miscarriage, fetal mortality, and low birth weight. So lastly, on anticoagulation during pregnancy, the use of warfarin is actually okay from weeks 6 to 12 gestation. There is a risk of warfarin embryopathy. It ranges from 1 to 30%. There's data to say that if your INR is less than if your dosage is less than 5 milligrams of warfarin, your risk of warfarin embryopathy is much lower. However, the miscarriage rate is still quite high. Again, this is also in the first trimester when miscarriage rates are high to begin with, spontaneously. The risks to the fetus include fetal loss, intracranial bleeding, and one of the factors that will go into delivery is minimizing bleeding risk both for the mother and also for the fetus. And as I mentioned, that there is less complications that have been observed with doses lower than 5 milligrams. Heparins during pregnancy, unfractionated heparin, subcutaneous administration is associated with increased bleeding. Low molecular weight heparin sometimes is the more preferred agent as it does not cross the placenta, and there is better bioavailability compared to unfractionated heparin. It has a longer half-life and more predictable dosing if you are monitoring anti-10A levels and less risk of HIT. The dosing is twice a day, though, subcutaneous, and so you'd have to have someone who'd be able to administer it to themselves to be able to maintain on this. These are very detailed, obviously, just to show you the references for the data from different societies. So from the American Heart Association, from the European Society of Cardiology, the American Heart Association, and then a combination, looking at what are your options for anticoagulation in pregnancy and what are the recommendations. So main thing is low molecular weight heparin should not be used unless you can monitor your anti-10A levels. So that is really what the big takeaway from the ESC guidelines. From the AHA, American College of Cardiology guidelines, one thing that is actually recommended is low-dose aspirin in the 2nd and 3rd trimesters with any sort of prosthesis, which has been shown to have lower event rates for pregnant patients with mechanical or bioprostheses. And then the only other factor in is for the older valves, an INR goal of 2.5 to 3.5 is reasonable from Warfarin strategy. So if you go down the algorithm, essentially the breakdown initially is for whether your dosing of warfarin is greater or less than 5. This is from guidelines that came out from Dr. Nishimura in 2014. And if your dosage is lower than 5, you have a little bit more liberal monitoring, but you are looking for monitoring by level. And if your dose is greater than 5, then you will then eventually move towards warfarin adjusted to the goal, plus adding on your aspirin, and then discontinuing warfarin and transitioning to a heparins post-delivery. Peri-Partum Anticoagulation is you hold warfarin after 36 weeks of gestation because this is an increased risk of fetal intraventricular hemorrhage with warfarin as it crosses the placenta, and you replace it with heparin, either unfractionated or you get admitted, or low molecular weight heparin. Safe to resume postpartum, and it is safe in breastfeeding. You hold any form of anticoagulation prior to delivery at least 24 hours prior to induction, and this is because of increased bleeding risk with regional anesthesia, and then it's safe to resume 6 hours post-delivery or 12 hours post-C-section. Mechanical valve thrombosis. So what if this happens? This requires an emergent TE, fluoroscopy, which, as we mentioned, you can do a abdominal shield to protect the fetus. But again, in the 3rd trimester, the amount of radiation that you're going to give to the fetus is really negligible in terms of risk. But you can fluoro the valve, so take them to the cath lab and see if the mechanical leaflets are actually moving. This follows non-pregnant treatment algorithms, which include anticoagulation, surgery in the signs of decompensated heart failure or cardiogenic shock, and thrombolytics for right-sided lesions, but the surgical, or if the surgical risk to the fetus is too high. Streptokinase is what you would use for the thrombolytics, and it prevents most fibrinolytic items from easily crossing the placenta. Those small fragments may pass. And alteplase is the one that you don't necessarily want to, is the one actually that you might want to use more so because it does not cross the placenta and it's ideal if needed. Streptokinase is usually what we have more available in many of the hospitals. For labor and delivery, epidural anesthesia with slow uptitration of the dose really is reasonably tolerated. Vaginal delivery with an assisted 2nd stage. Avoid prolonged Valsalva. Concurrent significant aortic diseases is the exception, as we discussed and reviewed, that you prefer C-section. And there's no indication for antibiotic prophylaxis in terms of endocarditis. Here is, again, so a lot of these big slides that I added are just to give you guys the reference of where to look for some of the guidelines and information. This is an article that came out in 2018 and Dr. El-Khayyam's from 2016, which has the information on specific lesions, imaging, delivery, and what the other variables would be. And then more importantly, I think, this is something that comes up on service a lot of times, is what medications are safe. So fetal safety of cardiac drugs during pregnancy and lactation. And this gives you a breakdown of which drug class it is, what is our clinical experience actually. Most of the risk categories are going to be B, C, or X. What happens, and then in breastfeeding, whether it's allowed or not, whether it's recommended or not. And then this is one of my favorite references that if you've been on service with me, I've usually emailed a copy to you, is from Dan Halperin at NYU, put out this article in 2019, which basically just is such a wonderful visual aid of a, traffic light style with the different categories of medications and whether or not they are safe to use in pregnancy, whether they are of limited data, and can be used with caution, or whether they are contraindicated. And so that's the graph on the left. And on the right side is if you wanted a little bit more detail and some more of the words rather than the graphics, and you have the information on the right side as well. So one thing just to point out is for hypertension, nifedipine. So we used to, we were taught that alpha methyl-dopa was the medication of choice for hypertension for pregnant patients in medical school. And then, slowly, I think the experience with nifedipine increased and people felt more comfortable. And so nifedipine has a clear okay to use in pregnancy and postpartum as well in hypertensive patients.